Welcome to the Clinical Education Initiative podcast, Conversations with CEI, where we feature conversations with clinical experts, their experience and insights on current health issues in the areas of HIV, primary care and prevention, sexual health, hepatitis C, and drug user health.
Hello, this is Stephen Fine speaking on behalf of the CEI training portion of the AIDS Institute of New York State. Several months ago, I did a podcast about injectable antiretroviral therapy, essentially long-acting cabotegravir plus long-acting rilpivirine, injected either once a month or once every 2 months for suppression of HIV. This approach may have several advantages for patients who don't like taking oral antiretroviral therapy, and we went over a lot of reasons that patients may prefer injectable therapy. A lot of them have anxiety for the possibility that they may miss doses. Some feel they may face stigma if others discover their meds, so they may be hiding their medications. Others find it difficult to travel with oral medications, or maybe they're traveling when they're not expecting to. But no matter what the reason, clinical trials leading up to the approval of injectable cabotegravir rilpivirine long-acting, all of the patients must be first suppressed on oral medications. So their viral loads need to be less than 50. This requirement wasn't without reasoning. In fact, there was quite a bit of concern that this combination, particularly since rilpivirine may have a lower barrier to resistance, could lead to resistance if not done appropriately or if started in patients who are not already virally suppressed. Remember, the half-lives of the injectables cabotegravir and rilpivirine are significantly different. Therefore, if patients were to stop taking the injectable regimen, they're often left with a long tail of rilpivirine alone. That may lead to resistance for non-nucleoside reverse transcriptase inhibitors. Therefore, since 2019, when long-acting injectable antiretrovirals were approved, it's been approved for patients who are already suppressed. However, all of us that take care of a great number of HIV patients were very tempted to consider using it in patients who are not suppressed. We all have a small group of patients that no matter how hard we try to address all of the barriers to adherence, some patients manage to stay unsuppressed despite being on what should be active oral antiretroviral medication. This is almost surely due to lack of adherence for patients that really are not able to adhere to the oral regimen. Certainly is tempting to consider long-acting injectables in those patients because perhaps they would benefit from it as they're not benefiting from their oral agents. In this podcast, I'm going to be reporting the results of some small clinical trials that address this question about starting antiretroviral long-acting cabotegravir rilpivirine in patients who are not virally suppressed. And then another trial, which is much larger, that was presented very recently at the CROI 2024 in Denver, that includes patients that were not able to be suppressed initially on their oral therapy, although they were suppressed briefly before the trial of long-acting injectables began. The first trial of interest was reported by Brock and others, January of 2024, in the Journal of Clinical Infectious Diseases. This group from Mississippi reported 12 patients that continued to have viremia on oral antiretroviral therapy who were initiated on the injectable cabotegravir rilpivirine without an oral lead-in phase. Prior to initiating the 12 patients on long-acting injectable, did look for historical resistance mutations, and 10 out of the 12 patients did at least have some resistance, including NNRTI resistance of K103N, which recall doesn't give you resistance to rilpivirine. Six of the patients were initially started on injections every month, but then were transitioned to every 2 months when they achieved virologic suppression. 6 of the patients were initially started on the every 2-month regimen. They found that adherence to the injections, so coming in for their injections, was quite good, despite the fact that these patients had significant struggle with oral medications. Patients that missed an injection were given repeat loading dose and then a subsequent injection within a month. Outcomes were quite good. Viral loads ranged at baseline from 2,400 to 566,000, with a mean viral load of 152,000 copies per mil. All patients in the trial were less than 50 copies within 3 months of initiation, and no patient in the 12-month follow-up has seen a viral load greater than 200 copies. 5 of the patients in the initial trial did have AIDS diagnosis with Candida esophagitis in 3 of them, cryptococcal meningitis in 1, and pneumocystis pneumonia in 1 of the patients. CD4 cell counts also increased in all but 1 of the patients. The initial baseline CD4 cell count was a mean of 233 cells per microliter, and the mean increase in CD4 cell count throughout the study was 184 cells per microliter over the year. Researchers in this trial acknowledge that starting patients who are not virologically suppressed on long-acting cabotegravir/rilpivirine required regular telephone follow-ups, sufficient appointment reminders, transportation assistance, and very aggressive proactive scheduling of missed injection visits. Noted that they also do have the luxury of a full-time registered nurse for case management and injection administration. However, that study certainly did lend credence to the idea that patients who are not virologically suppressed could, in some circumstances, be safely and effectively started on long-acting injectable cabotegravir/rilpivirine. Earlier this month, at CROI 2024, the Conference on Retrovirus and Opportunistic Infections, there was a really exciting study out of San Francisco from the HIV clinic that they call Ward 86. This presentation reported the 24-week viral suppression in patients starting long-acting cabotegravir/rilpivirine without HIV suppression initially. They reported 59 patients with an HIV viral load of greater than 50 copies per ml who were unable to take antiretroviral therapy orally. By the time the abstract was presented, they were actually able to comment on the 48-week data as well. Patients with viral loads over 50 copies per ml were started on long-acting cabotegravir/rilpivirine initially once every 4 weeks, but then after 3 to 6 months of suppression, they were converted to every 8-week injections. What they found was that at 48 weeks, 81%, or 48 out of 59 of the patients who did remain on the long-acting cabotegravir/rilpivirine were virally suppressed at less than 50 copies, and 93% were virally suppressed who were on long-acting cabotegravir/rilpivirine injectable plus another antiretroviral, and that 95% were virally suppressed if you counted less than 200 viral load as suppressed. Their approach was not without some hazard. In fact, 3 patients had virologic failure with emergent resistance. Those patients developed resistance within 8 weeks of initiation despite on-time injections, and 1 patient developed resistance when they stopped the injections but didn't restart any oral therapy. The broad conclusion was that they were able to suppress initially 93% of patients at 48 weeks to undetectable less than 50 copies, and 81% continued on the long-acting cabotegravir/rilpivirine therapy. This is a notoriously difficult to treat population of patients that are not able to be suppressed on oral therapy no matter what they do. And to me, therefore, the results are pretty stunning. The last presentation that I wanted to discuss was also presented at the 2024 CROI, although results had been released a little bit previously. The ACTG study called ACTG A5359, otherwise known as the Latitude study, was a slightly different patient population, but also worth considering when looking at this question about treating patients who are not virally suppressed. Cabotegravir/rilpivirine long-acting injectables. It was a much larger study conducted at, I think, 34 sites, and ultimately it enrolled 434 patients in what's billed as a phase 3 randomized open-label trial. The thing that differentiated this trial from the previous 2 that I talked about is that even though these patients were not able to suppress on oral therapy when they were enrolled in the trial, they were suppressed for at least a short period of time on oral therapy before starting the injectable long-acting cabotegravir/rilpivirine. So what happened is they recruited 434 patients for the first step and put all of these patients on oral therapy and very intense counseling along with monetary incentives for them to actually take their antiretrovirals and become virally suppressed. Out of those 434 first-step patients, 294 were able to be suppressed through intensive counseling and incentives. And then they were randomized. 146 received long-acting injectable every 4 weeks, and 148 maintained their oral HIV regimens. In February of 2024, just a couple weeks before the CROI presentation, there was an interim review that was already pre-planned by the Data Safety Monitoring Board, and that recommended that the study stop randomizing participants and offer long-acting injectables to all the eligible participants based on interim results, showing that the long-acting injectable was more effective or superior than maintaining oral antiretroviral therapy. Of the 146 that started the injectable therapy, there were 28 treatment failures at the time of the independent review. Comparatively, out of the 148 who maintained oral therapy, there were 47 treatment failures. There were no safety signals in that the injectable therapy was well tolerated, as it has been in previous clinical trials. These mostly consist of manageable injection site reactions. Although the data is still being analyzed, the two of the patients who failed in each arm did have virologic resistance mutations, including integrase inhibitor resistance mutations. So, as is already known, there definitely is some risk to this approach. I think one of the quotations quoted in the ACTG report of this abstract sums it up better than anything that I could say. Protocol chair Adi Arana from the University of Alabama at Birmingham said that until now, the population that was able to benefit from the availability of long-acting injectables has been limited to those with durable viral suppression on oral antiretrovirals and no history of failure on oral therapy. However, the findings that were shared today are an important step toward ultimately ensuring that people living with HIV facing challenges with adherence have access to a treatment option that meets their health needs, allowing them the potential to experience the health benefits of becoming virally suppressed. Basically, meaning that we have all been very tempted to treat our most difficult patients in the greatest difficulty adhering to oral antiretrovirals for whatever reason, and looking at those patients as possible candidates for the long-acting injectables. Indeed, in my practice, those are the patients that often request that they be put on long-acting injectables that they've heard about. Up until now, most of us have been disappointing those patients by maintaining that they need to be virally suppressed before starting long-acting injectable therapy. However, these are the same patients who are the least likely to become virally suppressed in oral therapy and the most likely to progress to AIDS because they're not virally suppressed. In fact, the IAS USA guidelines for treatment of HIV patients recently issued a change in their guidelines involving the use of long-acting injectable antiretrovirals. I believe these changes in the guidelines acknowledge the fact that some patients can't afford to play it safe and adhere to the restrictions that were initially put in place at the time of approval for long-acting injectables. The IAS guidelines now state, when supported by intensive follow-up and case management services, injectable cabotegravir and rilpivirine may be considered for people with viremia who meet other criteria when no other treatment options are effective due to the patient's persistent inability to take oral antiretroviral therapy. The criteria they cite are 1. Unable to take oral antiretroviral therapy consistently despite extensive effort and clinical support, and 2. High risk of HIV disease progression, such as CD4 cell count less than 200 or a history of AIDS-defining complications. And of course, the third criteria remains, which is that they need to have virus that's susceptible to both cabotegravir and rilpivirine. Well, in summary, we don't have the complete data. However, those of us who've been taking care of patients with HIV for a long time realize that we don't always need the complete data in order to try to help individual patients who are the most at risk. Although early, these data do seem to support considering starting patients on long-acting cabotegravir, rilpivirine, even if they're not virally suppressed in certain circumstances, if you're able to supply the needed support. And I am definitely starting to think of a few patients in my clinic that might benefit from long-acting cabotegravir, rilpivirine in light of these data. If you've made it this far, thanks very much for listening. You've been listening to the Conversations with CEI podcast. My name is Stephen Fine from Rochester, New York.
Thank you for tuning in. Join us next time for a new episode of Conversations with CEI. Visit us at ceitraining.org and follow us on CEI social media platforms.